Good morning, everyone, and welcome to our TIRO MDS Friday morning program. We really have an outstanding program with a distinguished international presenter as well as an outstanding discussant for this morning. I'm very pleased to welcome our presenter, Dr. Yasuhiro Ito, who is a consultant surgeon in the Department of Surgery at Kuma Hospital in Kobe, Japan. He specializes in endocrine surgery, which he has practiced since completing his Doctor of Medicine in 1988 and his Doctor of Philosophy in Medicine in 1996. His areas of interest include papillary microcarcinoma, thyroid cancer prognosis, which is the topic for this morning, and systemic therapy for thyroid cancer. He currently serves on the editorial board of Thyroid and the Endocrine Journal. Dr. Ito is recognized internationally for his prolific work in the field of thyroid cancer, and his work has had a profound impact on the way we practice thyroid cancer management throughout the world. So, Professor Ito, thank you. We are joined this morning by my colleague and friend, Dr. Louise Davies, who is professor and vice chair for quality in the Department of Otolaryngology at the University of Wisconsin-Madison. She has the unique dual appointment in the Department of Surgery and the Division of Endocrine Surgery. Dr. Davies is widely recognized for her clinical epidemiological research that identified the problem of overdiagnosis in thyroid cancer, and she has published and lectured on ways to mitigate that problem. I have told her on numerous occasions that she holds the record for the most widely utilized graft in all of medicine that shows the increased incidence of thyroid cancer over multiple decades and the disproportionate diagnosis of early stage disease. I have publicly accused her of receiving residuals every time that graft appears, but she has vehemently denied that. Louise, thank you so much for joining us this morning from Wisconsin. And so with that, I'm going to turn over the platform to Dr. Ito. And as always, I'd like to welcome our attendees to send in their questions. I am sure this will lead to many, many questions, and we hope to get to these as at the end of the presentations. Once again, Dr. Davies and Professor Ito, thank you so much for joining us.
Today's talk is about prognostic factors of differential thyroid carcinomas, DTC. Next, please. I have no COI to declare. There are two kinds of prognostic factors for DTC, static and dynamic factors. Next. There are three types of static prognostic factors of DTC according to when they are evaluated. Before surgery, during surgery, and after surgery. Next. Another one is dynamic factors that will be explained later. Thyroid doubling rate and tumor volume doubling rate. Okay, please. Next, please. First, I'm talking about static progress factors of PTC. Next, please. Papillary thyroid carcinoma, PTC, is normally diagnosed on cytological examination and frequently metastasizes to regional lymph nodes and often invades to adjacent organs. Next. The first topic is prognostic factors based on preoperative findings. Next, please. First of all, age is a very important prognostic factor. To date, several studies have published about the prognostic value of age. We demonstrated the prognostic impact both of young and old age. Two cutoffs, 40 and 60, and 30 and 60. And age is included in the staging system of DTC. Next, please. Next, please. Yeah. As shown here, returns, please. Yeah, okay. As shown here, both old and young ages are independent predictors of local regional and distant recurrence, both on univariate and multivariate analysis. In contrast, old patients, but not young patients, are likely to die of thyroid carcinoma, as shown in Table 6. Next, please. This summarizes the important points of age as a prognostic factor. Young age, likely to recur, but unlikely to die of carcinoma. Middle age, unlikely to recur and die of carcinoma. Old age, likely to recur and die of carcinoma. Next, please. The second one is clinical N, lymph node metastasis. Of course, this is an important prognostic factor, but further subclassification should be better for predicting patients' prognosis. Next, please. In the newest ATA guidelines, large node metastasis and extranodal extension are adopted as factors of high-risk features. Next, please. This slide compares prognosis among patients with N0, N1, I mean small metastasis, and N2, large, I mean larger than 3 centimeters, and or extranodal extension. Patients having large or invasive node metastasis show significantly poorer DFS and CSS. I will explain external extension again in the next section, prognostic factors based on intraoperative findings. Next, please. And regarding tumor size, of course, large tumor size has a significant prognostic impact. I'll introduce our data in the next slide, please. As shown in this multivariate analysis, tumor size larger than 4 centimeters independently predicts distant recurrences, local regional recurrences, and carcinoma-related death. Next, please. This summarizes prognostic factors of PTC based on preoperative findings. Young and old ages, young only for recurrence, and old age both for carcinoma death and recurrence, and large node metastasis and large tumor size are regarded as independent prognostic factors. Next, please. Preoperative prognostic factors are useful for decision of surgical designs, extent of thyroidectomy, and lymph node dissection. Total thyroidectomy is appropriate for cases with large clinical N and or large tumors. Extent of lymph node dissection depends on the presence and location of the nodes. Adjuvant radioactive iodine RAI administration is considered after total thyroidectomy for cases predicting poor prognosis. Next, please. The next topic is prognostic factors based on intraoperative findings. Next. Well, extranodal extension should be evaluated based on intraoperative findings. T3B in TNM classification indicates the invasion to the strap muscle, and such patients are upstaged to stage 2 if aged 55 years or older. Next, please. As shown here, in the subset of patients older 55 years or older, T3B N0 M0 showed a poorer prognosis than stage 1 patients, but prognosis is similar. I mean, lymph node recurrence rate, distant recurrence rate, and cause-specific survival rate did not differ between T3A N0 M0 patients and T3B N0 M0 patients. So, we can conclude that upstaging T3B N0 M0 patients to stage 2 is appropriate. Next, please. Yeah. Clinical T4A is a significant prognostic impact. As shown here, T4A tumors are defined as any size tumor with gross ectothyroid extension invading these organs, indicating that biological characters of T4A tumor significantly vary according to organs which tumor invades. Next slide, please. So the important critical question is that the classification of T4A is appropriate or not, because this category includes carcinoma with wide range of aggressive features and prognosis. We think that this category, this category is too crude to accurately evaluate tumor's biological aggressiveness. Next, please. So we proposed the two subclassification of T4A factor, as shown here in the paper published in 2020, T4A1 and T4A2. In the simplest terms, T4A1 indicates shallow invasion, and T4A2 indicates deep invasion. Next, please. And in the subset of patients 50 years or older, CSS of stage 2 patients and stage 3 patients with shallow invasion do not significantly differ. And T4A1 patients showed significantly better clinical outcomes than T4A2 patients. Thus, T4A1 patients may be better to be downstage to stage 2. Next, please. Indeed, in the subset of patients aged 55 years or older, T3BM0 showed a similar lymph node recurrence rate, distant organ recurrence rate, and cause-specific survival rate to T4A1M0. These show the appropriateness of both T3BM0 and T4A1M0 being classified as stage 2. Next, please. Okay, let's move on to the next topic, extranodal tumor extension, lymph node EX. It is not included, actually, in the TNM classification, but adopted as one of the high-risk features in the risk classification conducted by the Japan Association and Endocrine Surgery. And similar to extraterritorial extension, it is evaluated based on intraoperative findings. Next, please. We investigated the progressive value for CSS of lymph node EX. And in the subset of patients under 55 years, that it independently predicts carcinoma death of patients. And the same data was obtained in the subset of patients 55 years or older. Next, please. In summary, deep extrathyroid extension and extranodal tumor extension are representative prognosis factors on intraoperative findings. But similar to extrathyroid extension, subclassification may be better also for extranodal extension, and further studies are necessary about this issue. But actually, since the incidence of lymph node EX is much smaller than that of extrathyroid extension of main tumors, so this might make further studies quite difficult. Next, please. Intraoperative prognosis factors are useful for change in surgical designs. For example, changing from hemi to total thyroidectomy for PTC having these factors. Also, they are useful for decision of adjuvant RAI and close examination by TG and TGAB with DSS suppression. Next, please. And next, I'm explaining prognosis factors on pathological molecular findings. Next, please. First, Ki-67 leveling index or immunohistochemistry is a simple tool for predicting prognosis of patients. As shown here, high Ki-67 leveling index is an independent predictor prognosis factors both for DSS and CSS. Actually, the cutoff of Ki-67 leveling index varies according to the fixation of paraffin-embedded tissue specimens. Actually, at present, we set the cutoff at Ki-67 leveling index at 5%. This is an old manuscript submitted to the 2010. At that time, we the 1% and 3% considered appropriate. But now we set the cutoff at 5% because of the fixation of from embedded tissue sections may become better. Next, please. And there are some special pathological subtypes predicting poor prognosis. Tall cell subtypes and although rare columnar cell subtype and the new one, Hobnail subtype. Next, please. As shown here, PTC having tall cell variant component in 50% or larger of carcinoma lesions
showed significantly poorer disease-free survival. Next, please. Also, on multivariate analysis, torso variant has an independent predictor of carcinoma recurrence together with extraterritorial extension. So, torso variant, torso component, over 50% of carcinoma lesions is a very important prognosis factors, regardless of other prognosis factors status. Next, please. This shows the prognosis of hormonal subtype patients in our institution. At the time of 2020, we experienced 4 cases of hormonal subtypes, and 3 of these showed recurrence to various organs. All patients but 1 showed local or distant recurrence, indicating that hormonal subtypes has very dire prognosis. Next, please. Well, these figures are from a famous manuscript from Professor Singh's group, showing that prognostic value of TART mutations is they clearly show that PTC having both BRAF and TART mutations show a significantly poorer prognosis than others. Importantly, BRAF positive but TART negative, TART positive but BRAF negative cases had an excellent prognosis. But only patients having BRAF and TART mutations, both mutations had a very dire prognosis. Okay, next, please. Thereafter, Dr. Abina in Professor Sugitan's group also demonstrated the strong prognostic impact of TART mutation. But they did not investigate BRAF mutations. So there are cases with TART mutations as some cases with BRAF negative. But I think I think that's no problem for their studies because the incidence of TART positive BRAF negative cases is very low generally. Next, please. And in summary, these 3, cell proliferation activity, histological subtypes, and TART BRAF mutations are identified as static prognostic factors based on post-operative findings. Next, please. This slide summarizes post-operative prognostic factors. Ki67 labeling index, aggressive subtypes, and 30 mutations of useful post-operative prognostic factors. So clinicians should keep in mind the importance of pathological and also molecular findings. Next, please. Okay, let's move on to the next topic. Static markers of follicular thyroid carcinoma FTC. Actually, this includes a significant clinical question. Next, please. Contrary to PTC, FTC is generally diagnosed on post-operative pathological examination. Tumors are rarely invasive adjacent organs, but distant metastasis or recurrence is more often detected than PTC. Next, please. This shows classification of FTC in the most recent WHO classification. Minimally invasive FTC has minimal capsular invasion only. An encapsulated angio-invasive FTC has vascular invasion with no or only minimal capsular invasion. And lastly, widely invasive has extensive capsular invasion, regardless of whether vascular invasion is present or not. Next, please. Now, there arises one important clinical question. Is the definition of widely invasive FTC appropriate? Especially underlying region, regardless of whether VI is present or not. Is it really appropriate? Okay, next, please. In this study, we set distant recurrence as an endpoint. And this slide shows that the degree of vascular invasion significantly affected patient's prognosis. Prognosis became poorer from no invasion to foci of invasion for larger invasions. Next, please. However, degree of CI, that is, whether it is no or minimal invasion or wide invasion, did not relate to patient's prognosis. Actually, there are multiple interpretations of the meaning of widely invasive in WHO classification. In our hospital, we adopted the definition of widely invasive as gross extracapsular invasion. So this study is subject to
the definition. Anyway, degree of calcified invasion does not affect patient's prognosis. Next, please. Based on these Kaplan-Meier curves, widely invasive FTC with vascular invasion positive and encapsulated angio-invasive FTC with VI2 positive can be classified into poor prognosis group. But widely invasive FTC negative for vascular invasion should be classified as favorable prognosis group because its prognosis do not differ from that of minimally invasive FTC. And encapsulated angio-invasive FTC, VA1 positive, should be classified as intermediate group. Now, next please. Indeed, Japanese guidelines do not recommend the completion total thyroidectomy for vascular invasion negative widely invasive FTC and encapsulated angio-invasive FTC with more than 4 or more invasive foci and old age or large tumor size are recommended to undergo completion total thyroidectomy. However, in our institution, we don't care about the tumor size. So large tumors with minimal invasive FTC or widely invasive FTC, angio-invasive FTC, we do not perform completion total thyroidectomy actually. But anyway, in guidelines, these three factors are identified for the recommendation of completion total thyroidectomy. Okay. Now, next please. Regarding the appropriateness of the WHO classification, our findings suggest that encapsulated angio-invasive FTC cases may be better to be subdivided according to the degree of vascular invasion. The widely invasive FTC category should be restricted to vascular invasion positive cases. In addition, a more concrete definition of calcified invasion corresponding to widely invasion or further subdivision of widely calcified invasion is recommended. But this may be difficult, I think. Okay, next please. Now, the last topic is dynamic prognostic factors for DTC. Next please. The first one is thyroglobulin doubling time, TGDT. This was established by Akira Miyauchi in 2011 and a representative dynamic prognostic factor for thyroglobulin antibody negative DTC patients who underwent total thyroidectomy. Next, please. Their findings show that patients with short TGDT, TGDT shorter than 1 year, are significantly more likely to show distant recurrence. Next, please. And these figures show that patients with TGDT shorter than 1 year are much more likely to die of thyroid carcinoma, and those with 3 years or longer show an excellent CSS. Next, please. This shows the results of multivariate analysis. T shorter than 1 year, group 1, is an independent predictor of distant recurrence together with other conventional prognosis factors. Next, please. This shows the result of multivariate analysis for cause-specific survival. TGDT shorter than 1 year is an independent predictor also of carcinoma death. Next, please. Actually, calculation of doubling time is very complicated, but the calculator can be downloaded from our homepage at free of charge. I'd like you to use it efficiently, please. Next, please. Now, suppose that there are 5 patients, A to E, as shown figure 3A. Tumors of patients A, B, and C enlarge with time, but those of patients D and E shrink. If we evaluate these 5 by doubling time, the doubling time decrease from C to A, as shown in figure 3B. Doubling time decreased from C to A. However, for doubling time with minus values, it showed a larger doubling time, resulting in the discontinuities of DT or entire series, as shown in figure B. However, as in figure C, if we take an inverse of doubling time, the value correctly decreases from A to E. We designated it as doubling rate, DR. So, at present, We recommend doubling rate as a dynamic marker rather than doubling time. Next, please. For patients having distant metastasis, I mean M1 patients or patients having newly appeared distant metastasis, TGDR and tumor volume DR, metastatic tumor volume DR, larger than 1 per year are progressive markers of CSS. Therefore, that one, TGDR, the right one for TVDR. Next, please. On multivariate analysis, both are regarded as independent prognostic factors for CSS. Actually, I think we are short of time, so I did not explain about the initial NLR, neutrophil to lymphocyte ratio. This is useful only for M1 patients. To date, several manuscripts have published for many cancers, but as for thyroid cancers, in our study, this is useful only for DTC patients with distant metastasis. And initial NLR reaches over 3, patients' prognosis become poorer. So, and also similar to thyroglobulin, and NLR can be followed, and we can check changes in NLR rate, NLR value. So this can be used also as a dynamic marker. I mean surrogate marker for cases with TGAB positive. Okay, next please. This is a summary of the lecture. These are static markers for PTC and FTC, and they are dynamic markers of DTC. PTC, age, male sex, large tumor size, large N, M1, preoperative factors, and intraoperative factors, extrathyroidal extension, extranodal tumor extension. And postoperative factors, aggressive variants, high Ki67 Levin index, third promoter mutations. As for FTC, we can list old age, large tumor size, M1 as a preoperative markers, and extensive VI, widely invasive with VI, and high Ki67 Levin index as static postoperative markers. And we can adopt high TGDR, high TVDR as postoperative dynamic markers. Next, please. So these are conclusions. Evaluation of prognosis should be appropriately performed at pre, intra, and postoperative stages. Especially for postoperative stage, dynamic factors are very important to predict patients' outcomes. And a combination of static and dynamic factors may be very useful to predict patients' disease-free survival. Thank you.
That was excellent. Should I go ahead and share my slides to
Yes.
start our portion?
All set. Yep.
Perfect. It's a real pleasure to be here. And Dr. Ito, that was a really wonderful lecture. It's such a nice overview of all the things to think about as we think about patient prognosis. I've structured this so that I have one teaching point and then questions that I have. But if we have questions from the chat, we should entertain those as well if they're more relevant. But I had a first question to start with. Well, some of the things that you wrote about in this really excellent review were familiar to me. One in particular that was somewhat new to me was thinking about the value of the Ki67 labeling index. And I actually looked up to see if the College of American Pathology template for reporting on thyroid cancer specimens includes it. And at least in the copy of the template that I was able to access, I didn't see it. And I wondered, are you consistently using it yourself in the Japanese reporting? And is this something that's important enough so that we should consider adding it? We already do a lot of testing of our thyroid specimens. Does it add something different that can be especially helpful?
Yes, actually, not many institutions in Japan adopt Ki67 labeling index. But based on our data published in 2010, we have adopted Ki67 labeling index is for consideration for their patient's prognosis. But as I told you before, the cutoff is now changed to 5%. And but the cutoffs might be better to set by each institution. It depends on the fixation on peripheral embedded tissues. So that is
Oh.
a problem. That's a problem.
Oh, that's very interesting. So if an institution wanted to add it to their own template, it sounds like you would suggest that they first look at their own, perhaps historical data for a few years to
Yeah.
figure out what's the right level for them.
Yes, but
Hmm.
actually, as you know, the breast cancer for predicting the prognosis of breast cancer, Ki-67 labeling index is a very important factor. So
Right,
so actually we operate also the breast cancer patients. So
right.
we have to be careful to make the peripheral embedded tissues.
Hmm.
So also we adopted the same process of the fixation for peripheral embedded tissue specimens as breast cancer specimens.
Hmm.
So I think that's a good strategy. Institutions where breast cancer surgery is performed, it's very easy to
Hmm.
to prepare the
Okay.
suitable specimens.
So that's great advice. So it sounds like you would advise if institutions wanted to do it to maybe involve their breast cancer pathologists and then use some of the same techniques. That's
Yeah,
really
yeah.
helpful. Dr. Erkin had his hand up.
Yeah. So just to follow on that, because I think it's extremely interesting. Do you advise using or measuring Ki-67 in all thyroid cancers or just those with an aggressive phenotype?
Actually, we routinely perform Ki-67 labeling index, but of course, so tumors with um, so much qualification, uh, we cannot perform immunohistochemistry for Ki-67 labeling index. But otherwise, we try to perform it. But actually, moderate or high risk patients should be performed this uh, examination. As I don't think that the low risk is needed
Mm.
for evaluation by Ki-67 labeling index. So
Great.
moderate or high risk patients, at least, I recommend.
Thank you.
Well, let me move us on to just a teaching point that I thought would add to this really excellent lecture. The report, the paper has a really nice section on the influence of patient sex and summarizes the available research really well. And it got me thinking about a paper that we wrote a few years ago that really was aimed more at understanding how we overdiagnose women. We did make a little point about some of the risks to men, but I thought this might be a nice time to revisit it because we commonly say, oh, men have a poorer prognosis than women. But actually, when you look at the epidemiology of thyroid cancer, it shows that the population mortality due to thyroid cancer is virtually identical. So let me just talk a little about what that means in practice.
Mhm.
So population mortality is a measure of
Mhm.
like the total number of people in the population. In this case, the data that I'm showing here are from SEER.
Mhm.
So they're United States of America cancer data. So we're saying among all the people who live in the United States, these are the number that die of the cancer. And the blue, there's a dotted line and a solid line running along the bottom of the graphic here. And that shows the population mortality due to cancer. So it shows that actually an equal number of men and women die each year. It's like a ratio of like 1.08 to 1, right? So it's, I mean, for our purposes, it's that.
Mhm.
But what's really different, of course, is is who gets diagnosed and at what stage. So there are many, many more thyroid cancers diagnosed in women than men. So because the pool of women is so large, if you look at any given woman, the chances that she contains a lethal thyroid cancer is just lower than it is in men. And this becomes really clear if you look at who gets diagnosed with cancer, right? So the overwhelming majority of small papillary thyroid cancers, which are the low risk ones, least likely to result in a death, are diagnosed in women. The ratio is like more than 4-1. But as you get to the more lethal cancers, the ratio gets closer to a 1-to-1 ratio. So the larger papillary cancers, a little bit more equal. Follicular, now we call it oncocytic cancer, a little bit closer, and then medullary anaplastic, almost equal. So I think we get fooled by the fact that the pool of women is so diluted with low-risk cancers that we forget, well, I don't think we forget, but I want to make sure that we never forget that a bad cancer is just a bad cancer. And a bad cancer in a woman is just as likely to kill her as the bad cancer in a man. So we should never look at a woman and say, well, she had a T4A tumor, but she's a woman, so she'll probably do okay. That's actually not the right way to think about it. Likewise, a tiny, like 1.5 centimeter thyroid cancer in a man should not be looked at and say, oh, that's high risk because he's a man, right? So survival and also the proportions of who we see is not the same as population mortality. So mortality is actually the same in men and women. And an equal number of people in the US die of thyroid cancer each year. So a bad cancer is still a bad cancer regardless of your sex. And a low-risk cancer is still a low-risk cancer. So it's really more about who we tend to see in practice and sort of these mental heuristics that we have. Any other thoughts from Dr. Ito or Erkin or Shaha even to add to that?
Actually, in our hospital, male patients instance very low actually.
That's right.
So that may occur, may have a bias.
That's
also,
right. We get this mental bias towards
and
thinking,
also
all
actually,
cancers in men are bad.
Actually, in our own studies, discrepant data have been obtained about the proxy impact of male sex. So, therefore, I think that male sex may have a weak prognostic value, but its influence to patients' carcinoma death is quite limited, I think. So it may be better for us to adherent to the sex and the prognosis.
Yeah, I think it's who we see, and we tend to diagnose cancers in men less often and more often because of symptoms than in women for various reasons.
Louise, thank you for those comments. If I could just try to get to some of the comments coming or questions coming in from the audience for just a moment here.
Yes.
Dr. Bramwine has raised a question for Professor Ito related to something that I have questioned as well, and that is you talk about intraoperative staging, and do you rely on the surgeon's perception of extranodal extension, or do you rely on what the pathologist determines based on what they see under the microscope?
Actually, in Japanese guidelines, we do not adopt pathological extrathyroid extension or lymph node metastasis EX. So we only evaluate based on the surgical findings. On pathological findings, we do not adopt them anymore, actually. So because please.
Yeah, so sometimes, and the surgeon says there is extranodal or extension, and the pathologist says, no, we're not seeing it. So in this instance, you say it's the surgeon determination that's the most important.
Yes. Yes.
Okay, interesting. One other question relates to um, whether you put any merit in using lymph node ratio as a
Mhm.
prognostic factor.
Yes. So it is useful only for advanced cases. So actually, there are previous manuscripts published about the NLR and differential thyroid carcinoma, but the data are not so good. So we specified the M1 patients, M1 DTC or DTC having distant recurrence. So we got good data. So this is useful only for advanced cases. So
Okay.
yeah.
So I noticed that your discussion of extranodal extension is just extranodal extension is present or absent. And the latest ATA guidelines have gotten away from saying that you need 4 or more lymph nodes with extranodal extension. Yeah, so do you look at size of lymph node with E&E as being prognostically significant? Meaning, does it matter if it's a very small lymph node that has E&E versus a larger lymph node, or is E&E bad no matter what?
Actually, for young patients, we have a data that the number of nodes, lymph nodes metastasis, affects the prognosis of patients, actually young patients. Older patients, the size of metastatic nodes has a good prognosis factors. So there are difference in the significance of N factors according to patient age. And also about the external extension, uh, we classified two factors only, yes or no. That should be improved, I think.
Okay. Louise, do you have another?
Yes,
Yeah, okay.
yes, I do. But I didn't want to, yeah, here, I'll share again and then,
Mhm.
so one of the questions that I had after reading your paper was I thought it was very interesting that you had this nice historical note about how much our thinking about follicular thyroid cancer has changed in the last 15 years. And that,
Yes.
if people are thinking about papers they read 10, 15 years ago, they may not be relevant anymore. What do you think the most important new feature about follicular thyroid cancer prognosis that we should be aware of?
No, it's an adaptation of encapsulated angioinvasive FTC. This is a very important big issue. So the prognosis of each classification changed. So the only the recent published paper reliable about this issue.
Yeah,
Unfortunately.
yeah, that's very helpful. We talked about the,
If I could can I
yeah,
follow up on that just while you're on that topic? To question, so we have minimally invasive, angio-invasive, and widely invasive FTC. Do you look at these as being a continuum that, or are these biologically distinct diseases from a prognostic perspective?
You mean growth factors of invasion? You
Ye-
mean
Yeah, do you see these as just a continuum? If left alone, these would all they would ultimately become widely invasive, or is the biology different for each one of these?
it's very difficult, but actually, at least in our study, we have to conclude that the biological character of vertical invasion negative FTC, should be the same, independent of the degree of capsular invasion. We have to conclude that.
Okay.
So
All right.
yeah,
And on the same question, you talked about T4A1 and
yeah,
T4A2.
yes.
Right? Do you think those are biologically distinct, or just a question of when you where the disease is when you operate?
I think they are biologically different. I do think. Of course, the aggressiveness is different. Then prognosis different. I think.
Okay, you're on, Louise.
Yeah. So we talked a little bit about the neutrophil to lymphocyte ratio, and maybe just to come back to that, it sounds like you have found that that is most helpful for people with distant disease. Is that right?
Yeah,
Just to
yes.
confirm that, yeah. And for people who may not have used this much in their own practice, just if there are learners on our conference, it can be measured in blood or in tissue. And it's an inflammatory marker, of course, that reflects the imbalance between immune surveillance and tumor progression. It's
Yes.
already used in esophageal, liver, ovarian, pancreatic, and stomach cancer.
Yes.
So the application here is new, but it's a well-established characteristic. And
Yes.
what I think is helpful and kind of interesting to think about is as you see the increase in neutrophils, that is associated with an increase in cancer progression. And then the depression of the lymphocytes, they think represents a depression of immunological surveillance. So that's why the ratio is important. And a normal ratio is somewhere around like
Yes.
0.78 or something. So so that's why a ratio of like 3-to-1, as I understand it, is abnormal. So it sounds like distant disease is when we would really think about that in thyroid cancer. Okay.
Yes.
We have just a last moment. I wanted to come back to the age things just a little bit, because the results are really, like, if you look at the data, and you do such a great job in your paper of presenting all the data. So the cutoffs, I'm just going to read them out for people. The disease-specific survival cutoffs for low and high prognosis in all the papers that you cite, they vary from 48, 50, age 55, and age 60, and even age 62.5. So like the results are so all over the place. What does this mean about how we should think about age and prognosis?
Actually, we tried 30, 40, 50, 60. But anyway, 55 cutoff, 55 years cutoff should be good because it's adopted in the TIRO classification. And the problem is young age. Actually, we tried the 30 years or 40 years or something like that. So 30 years it should seem to be better for me. So that's I set the cutoff 30 and also 60 or something like that. It's very fuzzy.
It is very fuzzy. Yeah.
That's a great question, Louise. I don't think we could finish any discussion and related to prognosis without asking a question about artificial intelligence. That has to come in at some point. And I know Dr. Shaha was about to ask that question, so I'm going to ask it. So, Professor Ito,
Yes.
do you foresee that artificial intelligence may help to put all of these variables together to personalize a particular patient's prognosis? Do you think there's a way for us to take all of these factors and come up with the right answer?
Okay, it's our ultimate purpose, ultimate goal.
Okay.
But it's very far away.
Okay. All
Yeah.
right. Great. Um, I think we have covered all of the questions. I do want to call attention to our Voices of Wisdom podcast. A recent one has just been released. And before we finish up, I want to thank Dr. Ito and Dr. Davies for really an outstanding presentation, incredibly valuable work. Dr. Davies, incredibly insightful questions here. So thank you both for joining us this morning, and we welcome everybody back again next week.